हेलो। अमोल जी।
हाँ दीपक जी बोलिए।
हाँ सर, नमस्कार।
हाँ नमस्कार नमस्कार। ये- और कैसे हो? बाकी सब अच्छे हैं?
हाँ जी।
बाकी सब अच्छे हैं?
हाँ सब ठीक है
तो
सर।
सर ने अप्रूव कर दिया मेल पे। आप लोकली परचेस
हाँ
कर लो।
हाँ
हाँ।
जी हाँ जी।
हाँ
नहीं, आप एक काम करेंगे सर, उसकी कॉस्टिंग मुझे बता दीजिए आप एक बार। मतलब वेंडर से बात करके ना,
हाँ
अप्रोक्सीमेट कॉस्टिंग, तो मैं फिर उससे थोड़ा सा रेट नेगोशिएशन कर लूंगा।
मैं पता करता
मतलब
हूँ। हाँ पता करता हूँ।
हाँ। डॉक्टर विघ्नेश, हेलो। डॉक्टर विघ्नेश, कॉल कर। सर गुड इवनिंग।
हाँ गुड इवनिंग जी, गुड इवनिंग।
डॉक्टर विघ्नेश, गुड इवनिंग।
हाँ गुड इवनिंग, गुड इवनिंग। आवाज आ रहे हैं ना?
हाँ सर, प्लीज शेयर द योर पीपीटी सर। So Mr. Amol is there.
Okay.
Right, I
No,
have
but
the
It has been disabled.
Pardon?
No, it has been disabled. I'm not able to share it.
Yeah, Dr. Vignesh sir, we can check right now. I'm making a co-host. Yeah.
Okay, share हो रहा है अभी?
Yes, it's
Yes,
visible,
yes.
sir.
Sure.
Yes.
Now it's coming, na?
Yeah,
Yes,
it's
sir. Yes, sir.
visible. Yeah.
Sure.
Sir, your case will be the first one. So
Okay.
you have, you will present the first case. Then Dr. Shalini will present the case.
Sure. ठीक है. Okay.
Okay, sir.
ठीक है. Okay. I can disconnect now, na?
You can join at 6:10, sir.
Sure. Thank you.
And sir, Dr. Manish is joining. Dr. Manish Shetty.
Yeah, he'll be joining later.
Oh, thank you.
Thank you. 6:30.
उसके पहले मुझे घर जाना है.
कहाँ पे निकलना है?
Ma'am, namaskar.
Namaskar.
Namaskar, Doctor. Namaskar.
जी.
Jan. Yes, ma'am. Madam, please try to this thing, your PPT. Just
Okay.
share the PPT, ma'am.
Post disabled participant screen sharing.
Okay.
Please enable
Just wait.
Yes, madam. You can share your presentation.
Yeah. Is it visible?
Yeah, ma'am.
Yes,
Your
ma'am.
presentation is visible.
Visible, ma'am.
Yes.
Yes, ma'am. Okay, ma'am. Yes, perfect, ma'am. So, ma'am, first case will be discussed by Dr. Vignesh. He's from PGI Chandigarh. Then your case will be there, ma'am.
Okay.
But right now, ma'am, 5:45. You can join at 6:15, ma'am. After.
Okay. So should I leave now?
No, you can leave or you can be there. No
Okay.
issues. You want.
Fine.
Better you there only.
Yeah. Okay. Thank you.
Thank you, madam. Sir, good evening.
गुड इवनिंग कैसे हैं पंडित जी?
Fine, sir.
नमस्कार नमस्कार नमस्कार। आ गए हैं स्टूडेंट्स?
Yes, sir. Yes, sir. Yes, sir.
डॉक्टर विघ्नेश
Sir, Dr. Vignesh and Dr. Shalini, both are students, sir.
विघ्नेश हैं कहीं?
Sir, join तो कर लिया था sir अभी. Dr. Vignesh, yes, sir.
Good evening, sir. I have joined.
गुड इवनिंग डॉक्टर विघ्नेश। विच ईयर?
Sir, abhi third year, sir.
थर्ड ईयर, फाइन। दैट्स फाइन। यू आर प्रेजेंटिंग द फर्स्ट केस?
Yes, sir.
ओके। डॉक्टर शालिनी,
Good evening, sir.
गुड इवनिंग टू यू।
Sir, I'm final year, sir.
Both are final year students. Both are going to teach us today because you have to teach us, right? And final year students are always bubbling with knowledge, right? So first case is by Dr. Vignesh,
Yes, sir.
right? That's all right. And second is by Dr. Shalini.
Yes.
Dr. Om Kumar should be joining and Professor Manish Rathi should be joining. That's all right. That's all right. So we can take a break off. We start sharp at 6:30.
Yes, sir.
Both of you can try your slides at the moment. If you have not tried, you can share and check the slides. 6:30 sharp we start.
Yes,
Okay.
sir.
Sir, Dr. Preetpal Singh ji has joined
Doctor?
in place.
Good
Dr.
evening, sir.
Preetpal Singh ji, he has come in place of Dr. Om Kumar.
अच्छा, अरे डॉक्टर ओम कुमार नहीं आ रहे? How are
नहीं
you?
sir, he is busy with governors board of governors meeting sir today in our institute, so he won't be
Okay.
able to attend here.
Okay. You are the other professor?
Sir,
Right. Professor Prithpal Singh. आप डॉक्टर साहब कब से हैं वहाँ?
सर 2014 से हूँ सर यहाँ।
अच्छा, तो बेसिकली पहले उससे कहाँ रहे?
सर SGPGI का पास आउट हूँ।
अरे वाह,
2011-14 बैच सर।
बढ़िया। सो फैकल्टी में कितने लोग हैं अभी आपके IGMS में?
3 है सर, डॉक्टर ओम, मैं खुद और डॉक्टर प्रेम शंकर पटेल हैं।
ही इज ऑल्सो प्रोफेसर?
नहीं सर, अभी तो एसोसिएट है।
अच्छा, okay. No, it'll be pleasure. I think we all should learn from you and Shalini about this interesting case. Let's see how you unfold. So we can keep quiet for some time. We meet at 6:30 sharp.
सर
Okay.
सर
Dr. Preetpal ji, नमस्कार. Sir, नमस्कार. दीपक शर्मा.
हाँ दीपक जी नमस्कार।
नमस्कार. Yes, sir.
ही लीडर हैं यहाँ के।
सर
दीपक शर्मा जी ही माइक्रो लैब के कर्ता धर्ता हैं ये।
अरे नहीं सर,
नहीं,
सब आपका आशीर्वाद है।
डॉक्टर खेर में ज्वाइन 5 minutes लेट।
यस सर।
तो अभी मुझे फोन आया था कि ही इज ऑन द वे।
यस सर।
कंप्यूटर से 5-10 मिनट का अभी रास्ता है गूगल से।
यस
तो
सर।
अगर वो नहीं होंगे तो वी विल स्टार्ट दैट।
यस सर, श्योर सर।
क्या?
श्योर।
दीपक जी
सर। यस सर।
तब तक अगर ये हमारे जो स्टूडेंट्स हैं चाहे तो अपने स्लाइड्स का एक बार देख लें कि इट्स रनिंग वेल, वो शेयर करके वो सब।
सर हाँ सर, देख ले सर, चेक कर लिया सर।
ग्रेट।
हाँ मैंने चेक करा दिया सर।
ठीक।
ओके।
हाँ मिस्टर दीपक जी शेयर करने के लिए अलो कर लेना।
Yes, sir. Yes, sir.
प्रोफेसर साहब आ गए हैं।
Good evening, sir.
प्रोफेसर राठी जी, गुड इवनिंग सर, गुड इवनिंग, गुड टू सी यू। एवरी टाइम आई सी यू यू बिकम मोर यंग। तो कैसे हैं? हाउ इज चंडीगढ़ दिस टाइम?
ठीक है सर।
मॉनसून बहुत अच्छा रहा इस बार।
अच्छा तो नहीं रहा सर।
दिल्ली में तो बहुत
मतलब,
अच्छा, दिल्ली में तो
अभी
बारिश थी।
आज के पेपर में था कि चंडीगढ़ इज स्टिल 20% रेन डेफिसिट।
Oh, if Delhi is 20% plus.
ओके ओके
5 days back, it came that Delhi has already reached its normal.
हाँ
No, that's after many years. मैं क्या करता हूँ, मैं अपने टेरेस पे बढ़िया आराम से वहाँ बैठ जाता हूँ। और कभी कभी जब बरसात, ऐसा मौका तो कम ही मिलता है कि आप जब बरसात होती है सारे हॉस्पिटल में ही होते हो। तो अदरवाइज इफ आई गेट ए अपॉर्चुनिटी आई सिट डाउन एंजॉय द रेन। दिस टाइम आई एंजॉयड द रेन। हर साल मौका नहीं मिलता। दिस टाइम डेली गॉड हैज बीन काइंड टू डेली। और एएसएन चल रहे हो कि नहीं?
प्लान तो है सर।
बढ़िया बढ़िया, चल चल।
और सर
मैं तो इसलिए आईएसओटी भी कैंसिल ही किया, अभी कर रहा हूं मैं।
हाँ
मैंने कहा क्योंकि आईएसओटी पे पहले बनाया हुआ था 17th को जाए, 19th को आ जाए। फिर लगा कि 19th को तो उधर चल दें, फिर कैसे जाए।
नहीं एएसएन कब से है सर?
है तो 23rd to 27।
हाँ हाँ
तो अब जब जाओगे तो सिस्टर या कोई रिलेटिव को भी मिलने जाओगे 3 दिन पहले,
हाँ हाँ
तो वही हो जाता है। क्योंकि बाद में इस बार क्या है, दिवाली है 31 को। आफ्टर द कॉन्फ्रेंस यू कांट गो एनीवेयर, तब आपको सीधा आना पड़ेगा। या या
तो डॉक्टर खेर भी ज्वाइन करेंगे अभी?
हाँ हाँ, आज का कि वहाँ
अभी अभी
अभी हाँ, ही विल ज्वाइन। ही टोल्ड मी ही माइट बी 5 minutes लेट।
ओके ओके
5 मिनट पहले बात हुई थी। इसे मेरा घर में वो गूगल दिखा रहा है 7 मिनट। तो कहते मैं अगर लेट हो गया तो 2 मिनट में ज्वाइन कर लूंगा, आप स्टार्ट करवा देना।
ठीक है सर ठीक है।
Good evening, Dr. Manish.
हाय
Prithpal
प्रीतपाल,
here.
हाउ आर यू?
Sir, fine, sir. Here.
तो तुम क्या प्रेजेंट कर रहे हो कि क्लास ले रहे हो? क्या डॉक्टर ओम कुमार नहीं दिख रहे?
नहीं, आज ना एक्चुअली यहाँ पे बोर्ड ऑफ गवर्नर्स की मीटिंग है।
हाँ
वो भी लंबी चल रही है, हो सकता है 8-9 भी बज जाए।
ओके
तो
ओके
उन्होंने मुझे कहा, कल पहले ही कह दिया था, क्योंकि ये डेट पहले से फिक्स हो गई थी। परसों हुआ कि नहीं सर को रहना है वहां पर। यूजुअली वो रहते नहीं, बोर्ड के मेंबर नहीं है, बट डीन है तो उनको प्रेजेंट करना था अपना सर।
हाँ वही तो मैंने कहा कि प्रीतपाल ही दिख रहा है, डॉक्टर ओम कुमार नहीं। और उधर कैसा रहा बारिश पटना?
कम ही है सर इस बार तो।
हम्म, पंजाब हरियाणा भी कम था, मतलब आज ही पेपर में आया कि दीज आर ऑल रेन डेफिसिट स्टेट्स।
आई थिंक पंडित जी टाइम हो गया क्या, देख लीजिए। आई थिंक यू कैन स्टार्ट द स्टूडेंट्स इन। दीपक जी
स्टूडेंट्स तो ऑलरेडी आ रहे हैं सर।
आई थिंक फाइन।
Yes, sir.
तो आप स्टार्ट कर दीजिए,
sir.
टाइम हो गया।
Yes,
6:31
yes, sir.
Yeah.
Good evening.
एक मिनट एक
doc-
मिनट, तुमको नहीं बोल रहे विघ्नेश, एक मिनट।
यस सर।
नहीं मतलब ये आप सर बाकी अटेंडी स्टूडेंट की बात कर रहे हैं ना?
हाँ बिल्कुल नहीं,
Yes, sir.
ये
Yes,
माइक्रो लैब वाले स्टार्ट करते हैं फर्स्ट।
हाँ
yes,
हाँ, आई
yes,
थिंक
sir.
यू कैन स्टार्ट ऑफ।
Yes, sir. Sir, good evening, doctor. It's our pleasure to welcome you all for the Section 12 of Regain Challenging Case in Nephrology. It's an honor to welcome both the course directors, Dr. Lieutenant General P.P. Verma ji and Dr. Vijay Kher ji. I hand over the session to Dr. P.P. Verma ji and request him to take the session forward from here. Over to Dr. Verma ji.
Thank you very much, Mr. Deepak. It's a pleasure and welcome all the students and friends. We are at the 12th session of Challenging Cases in Nephrology. And today we have got two very interesting cases being presented by two premier institutes. The first case, the examiner is none other than Professor Manish Rathi, a master in the field of nephrology and a doyen in the field of lupus, I'll say. He has got phenomenal work and which is worth quoting for lupus nephritis. And it's a pleasure that he's here today. He's a revered teacher, liked by students, and he will be conducting the first case. And Dr. Vignesh, who is a final year student from PGI, he will be presenting the case. The second case will be presented from IGIMS Patna. That will be presented by Dr. Shalini Sinha. She is also a final year DM student, and Professor Prithpal Singh, who is a professor of nephrology at Patna. He will be the examiner for that case. And Dr. Om Prakash, rather Professor Om Prakash was to come, but he's tied down. But this doesn't make much difference. Professor Prithpal is again a very dynamic teacher. He has been trained at SGPGI Lucknow, and after that, he has been in the faculty for over 10 years there. I think, again, a popular teacher among his students, he will be conducting the second case. Professor Kher, who is the code moderator and my senior, he will be joining maybe in another 2-3 minutes. He has just got stuck near his house. So he will be joining once the case starts. May I request the first student, Dr. Vignesh, to start the case.
Thank you, sir. Good evening, everyone. I will be presenting today's first case. Our case is a 15-year-old female who is a resident of Chamba, Himachal Pradesh, and she is a student studying 7th standard. She presented to our OPD on 25th of June this year with history of loose stools for 3 days, fever for 3 days, and pain abdomen for 3 days. Before going ahead, we will present the background history for this patient. Her first presentation to PJ was in April 2024. When she presented, she had history of rashes over the cheek and forehead, sparing the nasolabial fold associated with photosensitivity for a duration of 15 days. Along with that, she had fever, which was intermittent, low grade, but not documented, not associated with chills for 10 days. And she had generalized edema, started with periorbital puffiness, more in the early morning, and progressive over the course of 10 days. And she had history of decreased urine output, which was not quantified, but there was decrease in the frequency of the urination, which was not associated with hematuria or frothuria or dysuria for 5 days. And she had history of oral ulcerations, which was painless, presented over the hot palate and buccal mucosa, which was not bleeding for 3 days. And she had also had, along this duration, she had joint pain, which was bilaterally symmetrical, involving the small joints of the hands, but with early morning stiffness with a duration of more than 30 minutes. But there was no swelling or redness, there was no muscle weakness, and there was no axial involvement of the joints. Along with that, she never had any bleeding manifestations. She didn't have abdominal pain, loose stools, or vomiting. There was no shortness of breath or cough or chest pain. There was no neurological involvement or no bluish discoloration of the fingers on exposure to cold, and there was no history of CAM intake during this period. For this above mentioned complaints, she was evaluated outside, where she was told to have high BP records with low cell counts and a creatinine of 2.5, and she was referred to PJ for further management, where she was told to have blood and protein in the urine, along with the creatinine of 4 milligram per deciliter. On examination, at presentation, she had high BP of 150/94 in right upper limb with no radioradial or radiofemoral delay, and she was febrile. She on general examination, she had pallor and periorbital with bipedal edema and rash, which was present over the face, which was macular rash and sparing nasolabial fold. Along with that, she had rash involving bilateral hands in the extensor surface, which was maculopapular. And there was no pus discharge from the rash, and JVP was not elevated. Systemic examination, CVS and RS were normal. CNS, she had no no abdominal findings, but per abdomen, it was distended but not tender with bilateral full flanks, and there was shifting dullness. In musculoskeletal, she had tender joints involving 16 out of 28 small joints, but there was no redness or swelling. And her urine output at presentation was around 1300 ml per day.
So this examination finding is in the admission when
Yes, in the initial presentation.
April 24.
Yes, sir.
Okay.
So based on this history at the initial presentation, along with the examination findings, we have the following differential diagnosis. Considering her creat to be rising from 2.5 in pre-admission, which was raised to 4, over a course of 10 days, we consider a diagnosis of rapidly progressive renal failure. Along with that, there was symmetrical inflammatory polyarthralgia. So the possibilities that we considered includes systemic lupus erythematosus, otherwise, or cryoglobulinemia. Even IgA vasculitis could have been considered, though it is not typical. Along with that, she had hypertension, possibly is secondary to renoparenchymal.
So Vignesh, can you stop for a few minutes here and then we can have discussion here? So you have said she is a 15-year-old female, right? And
Yes,
this
sir.
first presentation. So when she presented in April, like how long was the history?
So 15 days duration, sir.
Only 15 days duration.
Yes, sir.
So, and then you have said that this is rapidly progressive renal failure. So that will come to subsequently that why you have said rapidly progressive renal failure. But first of all, why you are saying this is lupus as first possibility?
So because of the typical rash, along with multisystem involvement, including arthritis, renal involvement, and
Arthritis, renal involvement.
renal involvement is there. Low cell counts, which was told outside.
Yes, or
And
what?
she had constitutional symptoms, though there is no localizing feature to suggest that it is because of an infection.
What else?
And typically, like it occurs in a young female, and
Yeah, young female, but yeah, they are usually young female, like middle-aged,
in middle age group.
childbearing age group. So she is still not that typical age group, but it can definitely occur. That is not an strong point against lupus. But I was asking what very glaring, which you have kept in the first line, but you are not speaking up. Joint pains, yeah, arthritis. Arthritis. So arthritis, malar rash, maybe cytopenia, renal involvement, and what else?
Why, sir? She had musculoskeletal involvement, along with the mucocutaneous involvement is there, and renal involvement in the form of rapidly progressing.
So what are the criteria which we use?
So right now we are using the classification criteria, ACR EULAR 2019 criteria to classify.
Right. So you have said these are classification criteria. What do you mean by classification criteria?
So in a classification criteria, it is mainly to enroll the patients in a research setting which should have high specificity rather than sensitivity.
What are other kind of criteria?
There is a diagnostic criteria, but for lupus,
what is difference between classification criteria and diagnostic criteria?
Sir, in diagnostic criteria, in classification criteria, it is to enroll the patients per se. Like we have to rule out that the disease is not there. So high specificity should be there in classification criteria.
High specificity is for classification criteria or for diagnostic criteria? So you are right that classification criteria are basically to classify the disease. So whenever you are dealing with a patient, you have to classify that whether this patient fits into the classification criteria. So like you have to enroll patient for any trial, RCT or any observational study, you just have to have a uniformity in inclusion, right?
Yes.
Uniformity in inclusion. So that means that, okay, these are the criteria which are more likely to have been present in a lupus patient. So that is why this is a classification criteria. But diagnostic criteria means you are actually diagnosing it. So classification criteria is not diagnostic criteria. Stay here on this slide only. So diagnostic criteria are more specific classification criteria are more sensitive because you have to recruit patients. You want more sensitive criteria. But when you are making diagnosis, you have to be specific. You are dealing with a particular patient and want to diagnose, so they are more specific. Okay. So coming to uvular ACR, so have you tried to fit this patient in uvular ACR? How many points are coming in this?
Sir, as per till this step, we can't include because ANA has to be positive for ACR uvular criteria of 2019.
How much?
So it has to be more than 1:80 in Hep2 cells or some equivalent method with some equivalent method.
So that is why there is necessity to have ANA positivity as an inclusion criteria in this classification criteria. But when you are diagnosing a patient, it may even be ANA negative. It's not mandatory to have ANA positive, although it will be very, very, you can say how many patients will be ANA negative lupus?
So almost 1 to 3% can be negative. So
Yeah, approximately 2% can be ANA negativity. But when you are using classification criteria, it is mandatory to have ANA positivity, just again to have a uniformity in inclusion. So, so suppose we leave ANA on. So if you have applied this clinical criteria, like how many points she comes into this thing?
So for constitutional fever, it is 2 points. And then mucocutaneous with mallar rash will be 4 points. And renal, we don't have a biopsy. But
So there is renal involvement. So how many points she will get minimum?
So minimum it will be 6 points, sir. If it is class 2 or class 5, she'll have 8 points, and the class 4 or class 3 or class 4, she'll have 10 points.
When is there 6 points?
Sorry, it is more than 500 milligram proteinuria.
So you are saying more than 500 milligram proteinuria gets 6 points, and then if it is class 3, it gets an additional 8 points.
No, sir. It has to be the maximum of that group, sir. If it is renal, the maximum points in the renal group has to be considered. If we have a biopsy report with class 4, then the 10 points will be given, even if the proteinuria and other things won't be considered.
Okay, right. Any other differential other than lupus in this case?
So considering typical features, we can straight away make the diagnosis of lupus, though like cryoglobulin and IgA vasculitis can be considered, sir, but they are very less possible considering the typical picture of the lupus.
Okay. So yeah, clinically she looks like a case of lupus only with all these kind of manifestations, but yeah, obviously you have to prove it with your investigations and further workup. So coming to renal involvement, you have said rapidly progressive renal failure with symmetrical inflammatory polyarthritis.
Yes, sir.
Why you are keeping symmetrical inflammatory polyarthralgia with the renal failure? So this polyarthralgia should have come in lupus, whatever manifestations you have kept musculoskeletal, that is there. Why
Yes,
you want to specifically highlight what is the importance of this? Why you are keeping this along with the renal failure?
Because if we consider just these two possibilities of RPRF with inflammatory polyarthralgia, even cryoglobulinemia can fit in that without lupus.
No, but first you have to deal with the basic disease. No, basic disease we are saying lupus. So irrespective of arthralgia or no arthralgia, what will be your clinical renal syndromic diagnosis?
It will be rapidly progressive renal failure, sir.
So irrespective of arthralgia, it will be rapidly progressive renal failure. No, you don't require arthralgia mandatory as a manifestation of rapidly progressive renal failure, or even for that matter, rapidly progressive glomerulonephritis. So you have kept 2 words, rapidly progressive renal failure and rapidly progressive GN, RP. So what is the difference between these two?
So rapidly progressive renal failure can include interstitial compartment also in the form of like if, not for this patient, but it can include cache nephropathy with multiple myelomas or even acute interstitial nephritis, which can go on for some time.
So what is the difference between RPRF and RPGN?
So RPGN is specifically involving the glomerular compartment alone. But RPRF includes interstitial
Glomerular
component.
compartment alone means what? Suppose in glomeruli there is thrombotic microangiopathy.
Yes, sir.
Do you call this as RPGN?
No, sir. We have to consider it to be RPRF because it is vascular compartment rather than
So
glomerular.
that's why. So when you are saying that it has to involve glomerular compartment, you have to be more specific. What kind of involvement is there?
When there is endocapillary proliferation or in where there is crescentic transformation.
Right. So if you have to answer in a single line, what is difference between RPRF and RPGN? What will you say?
Formation of crescent, sir.
So you will say RPGN is a pathological diagnosis and RPRF is a clinical diagnosis, right? So in clinical diagnosis, when you are saying, you can keep it later on in renal involvement that my possibility is RPGN and not AIN, but your clinical syndromic diagnosis will be rapidly progressive renal failure, not rapidly progressive glomerulonephritis. It is by biopsy. You will say that, okay, glomerular involvement and crescentic and proliferative, whatever is there, it is there on the biopsy. That was point number one. Point number two, why rapidly progressive renal failure?
Because creat has risen from 2.5 to 4 over a course of like 10 to 15 days. We don't have a definitive diagnosis for RPRF as such, sir, but considering the rapidity with which the creat progresses.
So what are other possibilities when creatinine rises like this?
We can consider nephritic syndrome per se.
Nephritic syndrome.
Yes,
So
sir.
in acute nephritic syndrome, what happens to creatinine? Is it rapidly rising?
No, sir, not as rapid as such.
What are components of acute nephritic syndrome?
Hypertension, azotemia, decreased hematuria.
And oliguria. So these are components. So, okay, acute nephritic syndrome is one differential you are saying. What else? What about AKI?
The AK can happen, but yes, sir, we can consider AK also, but usually it progresses within 7 days, almost within 7 days.
So something which progresses more than 7 days is?
It's AKD, sir. Like if it is less than 3 months, it is AKD, but we can consider like.
Then how you differentiate between AKD and RPRF?
Sorry, RPRF is actually a part of AKD. We don't have a definitive definition for RPRF.
You are not keeping AKD here. That if RPRF is part of AKD, you could have been more defensive, say it is AKD, then saying RPRF, then saying RPGN. You know? There has to be some differentiating features between AKD and RPRF. So AKI, you are saying progresses within 7 days. RPRF?
4 weeks to months, sir.
Months means?
Like less than 3 months. It has to be less than 3 months.
So days to weeks, less than 3 months, right? And similarly happens with AKD definition wise, it is days to weeks, right? Less than 3 months. So there has to be some differentiating feature between AKD and RPRF. It is there in the name itself.
So it has to rapidly progress.
Yeah, so something which is rapidly progressive over period of days is acute is rapidly progressive. Acute kidney disease or acute kidney injury. So acute kidney disease is a follow-up of acute kidney injury most of the time. So acute kidney injury happens, then suppose it either stabilizes or it remains like that or it improves. But if this improvement or if this renal dysfunction persists beyond say 1 week and less than 3 months of duration, this is acute kidney disease, right? So if you consider basket of acute kidney disease, RPRF will come into this. But clinically, there is a differentiation between RPRF. RPRF is a rapidly progressive renal failure. as in the name says. So in this case, when she was diagnosed outside, creatinine was 2.5. And then when she presented to PJ, creatinine was 4. So what was the difference between this? How many days difference was there between these two values?
So almost 6 days, sir.
6 days.
Yes, sir.
Okay. So now you are saying that this patient is lupus with rapidly progressive renal failure and RPGN. So suppose you do a biopsy, what is your expectation in the biopsy?
Sir, class 4 being most common, I consider had to have class 4 with possibility of crescents.
Any other differential?
She no, the class 4 being the most common thing, she will have class 4 only, sir.
Okay, so if she will have class 4 only, as per your statement, will you do biopsy? If you are so sure that it will be
No, sir,
class,
but still we can't be sure, sir. Like my first possibility will be class 4, but
so
she
that
can
is
have
what I
class
am
4 with
asking. What will be the differential? What
She
can also present with RPRF in patient of lupus?
lupus. TMA can present. She can
Yeah.
have a class 4 plus class 5 combination where treatment changes.
Or for that matter, class 3 can also
Yeah,
present.
plus 3 can.
So it most commonly it will be class 4. Suppose I say that it is class 4 only.
Yes, sir.
God has come to my dream and said that this is class 4 only. Then will you do biopsy?
Sir, still without biopsy, we can't be sure, sir.
No, I am saying that this is class 4. And subsequently biopsy will also show you class 4. Then also, if you are 100% sure, say for example, prior to biopsy that this is class 4, then will you do biopsy?
If we are 100% sure, we don't have to do biopsy, sir. But still, we
That
like
is
to
what is the catch. Even if you are 100% sure, you have to do biopsy. Why?
see the activity and chronicity index.
Yeah, so biopsy is not only class. There are many more things which also gives, which information is revealed by doing a biopsy. So one is activity index, chronicity index. What else?
Whether she has associated TMA.
Associated TMA, right? What else? Interstitial compartment, what is happening to interstitial compartment, whether it is associated with class 5 or not, right? So many information is given by biopsy, and then you have a baseline biopsy on basis of which you can also prognosticate, right? Suppose it is class 4, but along with IFTA, which is say 75 to 80, it is class 4.
Yes, sir.
And crescents are fibrous crescents. As compared to that, there is another class 4 which is having 100% active crescents without any IFTA. So the prognosis is different in these two group of patients, isn't it?
Yes, sir.
So that is the importance of doing biopsy. So even if you are sure that, okay, this is class 4 and nothing else, or class 3 or class 5 or whatever class, even if you are 100% sure, biopsy still gives you much more information than a simple class, right? Do you agree with me?
Yes, sir.
Okay.
Manish, what we will have is we will have to finish it in another
10 minutes.
10-15 minutes or so.
Right,
So
right.
I feel that we should move ahead
We will
also
go-
quickly
yeah,
to
we will move
complete the
ahead.
case.
Right. This is the
Can
main.
you just answer one? This is a child.
Yes, sir.
How does childhood lupus differ from adult lupus?
So the severity will be more in childhood lupus.
Anything else? What about the hematological features or neurological features? They will be more dominant in childhood lupus,
Yes, sir.
right? Go ahead with the investigations.
Yeah, this was the main discussion, sir. After that, we'll finish quickly.
Okay.
So coming to the investigations, this was a baseline investigation in April 2024, where she had pancytopenia with pancytopenia. Along with that, the reticount was 2%. There was no evidence of hemolysis, and creatinine was 4, and urine was showing active sediments with 24-hour urine protein to be around in nephrotic range of 5 grams. ANA was 4+, dsDNA was positive, both C3 and C4 were low, and APLA was negative. And she underwent a biopsy, which was showing 4 out of 12 cellular crescents. with all the gloms showing proliferative changes and thickening of glomerular capillary valve. And she is having a full house pattern suggestive of class 4 plus class 5 lupus with activity score of around 13 out of 24 and chronicity, nil chronicity.
What was the creatinine?
So creatinine was 4, sir.
2.5 to 4. So
Yes, sir.
then how will you manage this patient? Suppose at this stage, this patient presents to you.
So considering this much activity with 4 cellular crescents with RPRF presentation, I will consider NIH protocols, sir.
NIH protocol. Okay. Later on, if time permits, we can have discussion on this. You can go ahead.
Yes, thank you, sir. So actually, during admission, her creat rise to 6.5 and she had features of volume overload for which she was initiated on dialysis 3 per week via right IJV tunnel catheter, and she had received 2
Now you have more strong evidence of giving NIH. So now creatinine has further worsened to 6.5.
Yes.
And she has required dialysis. So now you can strongly debate in favor of NIH protocol, but not in the previous. Suppose it remains around 4 and she is not dialysis requiring. So at that time, one can debate that whether you want to give NIH or maybe ELNT can also work. ELNT has been tried up to creatinine of, so in the initial trial, it was 2.5 only, but people have given even in 4, 5. On the other hand, there are also reports of treatment of with MMR, with active disease and creatinine of 4 to 5. So one can debate on that, but yeah, in this stage, like with dialysis requiring renal disease, we don't have other option other than giving NIH regimen, right? Go ahead.
And so she was treated with NIH regimen with endoxin 750 milligrams, and she was discharged on dialysis. In the follow-up, by around May 3rd week, her dialysis was stopped as creatinine decreased to 2.5 with adequate urine output of more than 1 liter, and her edema also had improved. And she had received second dose of endoxin during that period, and she was on tapering course of steroids, and her creatinine improved by around June 1st week. Her creatinine improved to 1.2. Following this, on June 25th, she presented with the following complaints of loose stools for 3 days with fever and abdominal pain.
Meanwhile, how much steroid she was taking at this time?
So at this time, when May presentation, she was 25, sir. At this presentation, she was on 20 mg.
20 mg steroids are already on.
Yes,
okay.
Sir.
Okay, go
she
ahead.
Had history of loose stools, which was watery and
NIH protocol was on. So the first dose was given in April?
Yes, sir, April, sir.
And that means now she has come in June. She has received almost 3 pulses?
Sir, she has received 3 pulses and 2 doses of endoxin, sir, actually. 3 pulses of methylpred and 2 doses of endoxin before this admission. She was planned for endoxin at this period, but when she presented with these complaints.
Okay.
Loose stools were watery and frequency of 4 to 5 times with large volume and poorly formed stools, and there was no blood or tenesmus or urgency. And abdominal pain was acute onset, which was diffuse and crampy in nature, which was continuous and aggravates with food intake, and it was associated with abdominal distension also. And the fever was intermittent. There was no documentation of the grade, and it was associated with chills, 1 spike per day, and it was relieving with antipyretics. And it was associated with worsening of the generalized edema with facial puffiness, and she had reduced appetite with easy fatigability. There was no jaundice or vomiting, no decrease in urine output at this point, no cough, shortness of breath or chest pain, no ocular oral dryness, no oral ulcerations, no CNS manifestation or bleeding manifestations. On general examination, her vitals were stable with BP of 124/80, and she was normovolemic and regular. Pulse was regular and normal in character. Her respiratory was around 20 per minute, and the temperature was 100 degrees Fahrenheit. And she had pallor with anasarca, and malarial was still present, but the musculoskeletal symptoms had improved. On systemic examination, CVS, CNS, and respiratory were fine. On abdomen, she had diffuse tenderness with no guarding, but it was distended and the flanks were full. So at this point, considering she had received 2 doses of endoxin in a lupus patient, the possibilities that we were considered includes acute gastroenteritis, which can be possibly bacterial, or viral enteritis, likely CMV, or bacterial peritonitis we are not sure whether it is spontaneous or secondary. And the final possibility
Was
that we
there any ascites this time?
yes, sir, there was ascites with flanks are full, sir. Distended abdomen is flank full.
Okay, so that was persisting since beginning. And what was serum albumin? Okay, we don't know this time.
Yes.
Before that, has serum albumin improved and what else? Okay, so go to the next slide. Possibilities. Yeah. So obviously, somebody who is on endoxan, first possibility will be because she has already received an aggressive immunosuppression. First possibility will be infection.
Yes, sir.
You have also kept lupus enteritis. Why? There was no blood in the stool.
No, sir, no blood in the stool. But that was considered as a lost possibility, sir. Though the infection will be my first possibility in this patient. Considering I had to have lupus in the background, I consider lupus enteritis also, sir.
But everything else, lupus was getting better.
Yes, sir.
Kidney function improved and she was looking better and all that. So from that perspective, it would be very odd to have lupus enteritis. Don't you think so?
Yes, sir. Lupus enteritis won't be my first possibility, sir.
Yeah. Okay.
So other than viral and bacterial, what other infection can occur causing these symptoms?
Sir, atypical organisms like Cryptosporidium could have
all these protozoal infections
infection.
also occur. They are more common than occurrence of CMV and other things. Go ahead.
Sir, can it be acute pancreatitis? Dr. Vignesh,
So there
can
was
it be,
no history of vomit. There was no vomiting.
No
Because
pain.
she has received significant steroids, so steroid-induced pancreatitis, something like that.
Yes, it could have been a possibility, but considering she had no vomiting, which was very odd for pancreatitis, I didn't consider, sir.
And predominantly, it was loose motions, so watery diarrhea, which is not a typical presentation of pancreatitis. Okay, go ahead.
And this was the investigation during her admission with raised total count and creatinine was 1.1 with low albumin of 1.6 and CRP was high and normal C3 and C4. During her course, albumin stayed at the same range, almost 1.6 to 1.4.
Albumin is very low, but
Yes,
another important thing is that TLC went down from 12,600 to leukopenia kind of range. So what was happening?
Sir, initial on the admission, everything is suggestive of infection rather than the lupus activity because total count is high, CRP is high, normal C3 and C4.
Right.
But as we go on, like after around 7 days,
you have not said anything about when you were saying in 2-3 months she has improved in terms of renal function because serum albumin is still very low. What was happening to her proteinuria?
So we have the next one. So proteinuria is still 6 grams.
Okay. Right. Go ahead.
Yes, sir. But as we go on, the total count decreases to 3,000 and CRP also decreases. CRP is around 2.4 and 1.6. And there is a low C3 also. And this is X-ray presentation, which was not suggestive of perforation. And USG was done, which was grossly normal, other than moderate ascites. And this is the ascitic fluid analysis, which was showing raised TLC of 5,900 with neutrophilic predominance and high sag ascites. And urine protein examination is showing active sediments with 15 to 20 RBCs and 3+ protein. And 24-hour urine protein is almost 5.6 grams.
So there was peritonitis?
Yes, so there was peritonitis, possible peritonitis.
Right.
Okay.
And significant activity was there in urine in terms of RBCs and consistent proteinuria. At least renal functions have improved, but not this.
The proteinuria part has not improved, sir.
Okay, go ahead.
And infective workup, blood and urine culture both were sterile. And but Procal at the initial admission was a little raised, 0.8, which on follow-up decreased to 0.4. And the activity-wise, anti-DNA, dsDNA was negative, and Aplo workup was negative. And stool workup was negative for almost all the organisms, and culture CTT, everything was negative, though calprotectin was raised. And CME virology was sent, which was showing 6,500 international units per ml. where the lab cutoff was more than 10,000 to be considered to be positive. So with these findings, we did a CECT for this patient, which was showing thickened bowel loops with target sign, and there was some mesenteric. Here we can see there was some mesenteric striations, which are mesenteric arteries, which are accentuated mesenteric arteries. And
Okay.
yes, so
No, that's all right. So you are suggesting enteritis, lupus enteritis. Hmm?
so we could have considered, but the issue is she has a CMV positivity, and the activity as such was not that much, because creat improved and she was doing fine with the acute
What
fever.
improved except creat? What improved? She continued to have active urinary sediment.
Yes, but creat was
Proteinuria was
improved.
5.6 grams. RBC persisted. She
Yes,
had hypoalbuminemia. She is developing ascites. What improved except creatinine?
creatinine. Yes, sir.
That's all.
Serology also became
It's a
quiescent.
serology. DS-DNA negative became negative, and C3, C4 became normal. So serologically, she has improved. So sure.
Okay.
Okay, go ahead. Go ahead.
Yes, sir. And UG scopy was done, which was normal study, and the biopsy showed a mild lymphonuclear inflammation and no viral inclusion bodies. So at present, at this stage, we have a bacterial peritonitis which was proven, but which was not it was not explaining the small bowel diarrhea. And at this stage, she has active urinary sediments with low C3.
Okay.
So initially, we treated her with IV antibiotics in view of possible bacterial peritonitis and infective diarrhea. She also received, after developing leukopenia, she also had received filgrastim. Loose stools had improved initially, but abdominal pain persisted. So with titers of CMV being around 6,000, possibility of infection secondary to CMV was also considered, and she was started on IV ganciclovir. And but the CECT which was done showed a possibility of lupus mesenteric vasculitis, and now we have evidence to suggest that there is disease activity in the form of RBCs with low albumin and low C3 with low CRP. So considering a background of infection, we started her on IVIG, which was given for over 5 days, and along with that, IV ganciclovir was also considered. After this, with repeat procal being negative and CRP also on the lower end, we planned to give third dose of cyclophosphamide, and third dose of cyclophosphamide was given. Along with that, there was improved. By the time, patient was an improving trend also, and Vislone again was increased to 20 mg, and she was shifted to oral valganciclovir at the time of discharge. And she was last time she was on 15 mg per day Vislone, and fourth dose of cyclophosphamide has also been given now.
So do we have any repeat values, urine examination, proteinuria, serum albumin counts, anything latest?
So this is a latest that we have. So after that, she is supposed to come. She is yet to come, sir.
No, but on 10th August, she has come for this thing. Do we have any reports? Okay. If
No,
it, it's okay. So it looks like a combination of infection as well as disease activity, although some parameters have improved, but as rightly pointed out earlier by Dr. Verma, that some things only creatine improved, serology became quiescent, but other things were persisting. So some activity was still persisting, and still it's only 2 to 3 months of endoxin. So it takes some time to disease activity to go down completely. But
does this child have podocytopathy? Why so much of proteinuria? Creatinine has improved.
Yes.
You are saying C3, C4 have improved. Is there a podocytopathy that the child is having so much of proteinuria, ascites?
So we don't have the EM report, but with the element IF, we have just class 5 part also, sir. And class 5 part can take time to improve. So
No, biopsy shows 5 also.
Can podocytopathy, can you diagnose podocytopathy in presence of class 4?
no, sir, LM has to be actually normal, and only EF finding will be there.
So the classical description is class 1 and 2 with significant proteinuria with food process effacement, because EM with food process effacement can be because of class 4 itself. So actually the point, but what Dr. Verma wanted to mention is significant proteinuria, which was there. So is it, so in this case, this significant proteinuria may be because of associated class 5. So class 4 can also have significant proteinuria, but on top of it, there is also combination of class 5. So, and anyway, it's only 3 months, so it will take some time. Proteinuria takes some time to improve. But podocytopathy, by definition, is class 1 and 2 only, right?
Yes,
With
sir.
significant nephrotic range proteinuria, then you label this patient as podocytopathy.
And they respond very well to steroids.
Maybe, may not be, right? So we have seen our patients, sometimes they don't respond to steroid. Okay, go ahead. Have you finished your presentation?
So
So
for
what
the
is the role of IVIG in this patient? IVIG was given.
So IVIG is usually considered when the patient has a possibility of infection which we can't rule out. So it has a role there.
What about rituximab or giving anti-CD20 therapy in this case?
Sir, if we consider it to be refractory, we can give rituximab, sir. But in this patient, the problem is with the infection, with the possible background infection. So we couldn't consider CD20 therapy.
No, but you have given repeat endoxin, no? That is why I am asking if there is infection, then you will choose rituximab maybe
For the later.
on priority than endoxin, because endoxin is more aggressive immunosuppressant agent. Yeah, but the role of rituximab is not that
Yes, sir.
in refractory. So people have given, but usually response rate are not very good.
But I have one question. How sure are we that this is lupus enteritis and not CMV? Because CMV was also positive as far as, and this could have been just a CMV enteritis itself.
Yes, sir. It could have been a possibility, but biopsy was not showing any inclusion bodies as such to consider CMV enteritis.
I don't know. It depends also on how much the pathologist has looked at these and how good they have been. I know PGI has very good pathologists, but still, depending on whether the biopsy was, because you may not find inclusion bodies always.
Yeah, and the biopsy was also not showing you features of enteritis. You know, lytic lesions were not there in the biopsy. So what Dr. Kher is saying is very valid point, because if you go to CT, if you can go back again to CT, you see a lot of bowel edema, and this bowel edema is basically because of hypoalbuminemia. This typical, because entire, it is not a patchy that some areas are showing you, and it is a diffuse bowel edema, which can very well be explained by your hypoalbuminemia. Only maybe some radiologists have this target sign, what you are saying, this for mesenteric this thing ischemia.
Yes, sir.
Maybe an overinterpretation, but we cannot be sure that, because otherwise serology is quiescent, patient has clinically improved in terms of renal function, because these are usually an aggressive manifestations of lupus. Unlike proteinuria is not an aggressive manifestation. Renal dysfunction, lupus enteritis, neurological, myocarditis, these are all aggressive manifestations. So they are usually associated with an active serology and active clinical presentation of lupus. So, but there is no way to differentiate. You have already done biopsy. So that is why maybe to be on safer side, you have given both the therapies. Anyway, repeat endoxin was required in this case. So only additional thing which you have done, I think, is IVIG. But what about CMV? The CMV, you are saying the lab cutoff was more than 10,000 and it was only 6,000, and the biopsy was also not showing.
That is what.
Actually, whether we were dealing with CMV also or not is the question.
Sir, actually, issue is CMV enteritis can be present without the viremia.
Viremia, yeah, that's
Yeah,
also true. No, I think I don't know what is the 10,000 cutoff. It seems to me, which kind of is it a PCR or what was done, or this was some other test?
No, PCR, sir.
PCR, the usual cutoffs of 10,000 to me, I don't know, maybe
No,
different labs will have.
Yeah, that.
Different labs may have different cutoffs, but I thought 10,000 was too high a cutoff.
Yeah.
Most PCRs have a cutoff of about 1,000 or
1,000.
2,000. Yeah.
Just two small queries to Vignesh. One is does enteritis, lupus enteritis always correlates with the activity of the disease? Because I believe there are large, you must have gone through the literature.
Yes, sir.
Is it always when the disease is active, only then the this lupus enteritis occurs? And secondly, I want your comment on this young girl about the gonadal toxicity of this NIH regime.
Sir, when I looked through, I couldn't find anything to suggest that it has to be always associated with the serological positivity.
Yes.
Because it's kind of rare. It occurs only in like 2 to 9% of patients.
Hmm.
And second thing regarding
What is mentioned is lupus enteritis is a severe manifestation of lupus.
Yes,
As I said earlier, it is neurological, myocarditis, renal dysfunction. Similar to that, lupus enteritis is a severe manifestation. It is not a mild or moderate manifestation. So it requires an aggressive immunosuppressive therapy. And that is why it is usually associated with a severe disease, active disease. So serology may be quiescent, may not be quiescent, but it is considered as a severe manifestation of lupus. That is for sure, right? So it requires an aggressive immunosuppressive therapy. And second question was you were
regarding
gonadal toxicity.
gonadal toxicity. Yes, sir, there is a possibility, but considering her severe disease state, we had to consider NIH protocol, sir.
What is the risk of gonadal toxicity in her? So in child, the toxicity is going to be much less.
So it is important for you to mention, is she pubertal or pre-pubertal?
So she has attained puberty, sir, actually. She has attained
You
puberty.
have not mentioned, because this is an important consideration when you are considering gonadal toxicity. So in pre-pubertal child, the toxicity may not be of much concern, but if the child has achieved puberty menarche, then there is chances of toxicity.
So logically, the risk is much less in children vis-a-vis adults and older age group. So possibly, if I am not mistaken, the risk is just around 5 to 6% for such age children, because the toxicity depends on logically the age of the person and the number of pulses you have given. Fine. Any comment, Professor Rathi, on before we go to the next case?
No, sir, I'm done from my side. Only in chat box, there is one comment that role of IVIG in this case. I think we have already discussed.
In the setting of infection, it was doubtful how to go about. So that is possibly the IVIG was given. Yeah. Professor Kher, sir, any comment?
No, I think that this kind of a patient requires actually a greater sort of time for discussion. But since we have two cases, so I think we had to limit discussion. I think it was very good. I think
Very
overall, very interesting patient. If it is enteritis, I'm still not 100% sure that it is lupus enteritis. But if it is lupus enteritis, it's very interesting. Although I'm still doubtful about that.
Well, thank you very much, Vignesh and Professor Rathi, for very interesting case. And we have not discussed lupus enteritis before in this forum. And I think the audience should know there are cases, I mean, if I am not mistaken, over 100 cases have been reported of lupus enteritis. And as discussed, it's a very severe disease and it requires aggressive immunosuppression. With this, we stop here. And Kate, sir, if you can call the next speaker.
Next
Shalini.
one is by Dr. Om Kumar.
Dr. Om
Professor
Kumar,
Om Kumar.
Yeah, he could not come. So Professor Prithpal is there because there was a governor's meeting.
Okay.
So number 2, Professor Prithpal is here.
Okay. So maybe Professor Prithpal, you can introduce. I didn't know about it also that he wasn't here.
Sir, I am Dr. Prithpal Singh, additional professor, Department of Nephrology, IGIMS. I have done my DM nephrology from SGPGI from 2011 to 2014.
Yes, Dr. Prithpal. Who is the resident who is presenting?
Sir, Dr. Shalini Sinha will be presenting a
Shalini?
case.
Yes,
She is,
Dr.
she is,
Shalini.
sir, she is
Good evening,
final year
sir.
student.
Okay. Shalini ji, please go ahead.
Yes, sir. Thank you, sir. If you will enable me to share my screen, please. I'm not able to share my screen. Kindly allow me to share my screen. It has been disabled. Am I audible?
Mr.
Yes, you
Deepak,
are.
Yes.
Yes, you are audible. Deepak
Mr.
ji.
Deepak, please help her.
The screen sharing has been disabled by the host, says.
Mr. Deepak, am I audible?
You are audible, but I don't know whether Deepak is listening to you. Deepak ji.
Srinath ji. Srinath ji.
So by the time they come, I think you can start the case presentation.
Start the verbal.
You know the details or you don't know?
Yes, sir. So, good evening, everyone. I'm presenting a case of a 14-year-old male, a resident of Bihar. He has come. He had a history of intermittent fever and sore throat for 3 to 4 days, like 20 days back.
शेयर नहीं कर रहे आपका कोई याद Yeah, you can go ahead, Shalini. 14-year-old boy.
Yes, sir. Sir, he had a history of fever, low-grade fever, 99 to 100 degree Fahrenheit, with some cough, mild degree of cough, runny nose, for 4 to 5 days, like 20 days back, which improved by some conservative medications, and he was well for 20 days, next 20 days. Then he started to have reddish color urine, which was light pink to begin with, but in a span of 2 to 3 days, it progressed to dark cola colored. He also developed mild pedal edema, and with this complaint, he presented to us, and in the next 5 days, he also started having nausea and vomiting. So with this, he was evaluated outside, and his serum creatinine was around 2.1, and he had he was told that he is leaking protein and blood in his urine. And again, in a span of 2 to 3 days, again, investigation was done, and the creatinine has risen up to 3.8. With this complaint, he presented to us, and at that time, we found his blood pressure to be high. It was 150 by 100 millimeter of mercury, and he was having mild edema, but he was looking okay. Urine output was good, 1 to 1.5 liter per day. Mild pedal edema was there, and otherwise he had no history of any systemic manifestations like joint rash, joint pain, rashes, etc. So we admitted him and evaluated the. Now I think my screen is visible. If I can have just a moment.
Can we have the slides, Mr. Deepak?
Yes, sir.
So you are giving a history of a 14-year-old boy
Yes,
who
sir.
suffered from upper respiratory tract infection,
Yes, sir.
lasting 4 to 5 days. After 20 days of this episode, he presents with edema feet and
Yes, sir.
weakness
Deranged
of-
renal function.
And that is the time they find that there's edema feet, hypertension, and the creatinine has risen to 3.8. But mind you, you said urine output was adequate.
Yes, sir.
Okay.
So, are my slides visible now?
No,
No,
not,
No.
not yet.
you can
I
tell
have, yeah. So upon admission, we sent his immunological workup, and at when he presented to us, he had a hemoglobin of 6.7. His serum creatinine was quite high, 6.15. Serum albumin was 3.2, and cholesterol was high, 326 milligram per day, and rest of the electrolytes were within normal limit. Hello. Okay, I will try. Thank you. Sir, I will try, and sorry for
please try that.
this. Is it visible?
Yeah, visible.
Yes.
Yes.
You can make it full screen if possible.
Mr. Deepak, if you can share the slides which I have sent you. No, sir, I will go ahead with my slides.
Yeah, you can keep till the time they share. You said his hemoglobin was 6.7 grams.
Yes, sir, 6.15, and serum albumin was 2.5.
Okay.
And urine RM showed protein of 3 plus, RBCs were 20, burst cells were 5 to 7. And his 24-hour urine protein was 3.2 grams per day. Chest x-rays were normal. And USG was also normal, bilaterally normal size kidney. And we had seen the immunological workup and the viral markers, which the viral marker was negative. So with this, we kept a working diagnosis of acute nephritic syndrome, with RPGA, and with the possibility of PIGN, my first differential, immune complex mediated GN, the second, maybe IgA nephropathy and lupus nephritis class 3 or 4, the very low down. So
No, your
with
first
this finding,
impression is what? The first impression is it a rapidly progressive renal failure? Yeah.
sir, so the child had a history of URI symptoms like 20 days back, and he presented to us with hematuria and mild edema and hypertension, though his urine output was okay. So
Go ahead, next slide. Please keep moving.
sir, are my slides visible now?
Yeah, now
Yes.
they are visible.
Okay.
Next one.
So
Yeah, we are coming here.
yes, sir. These are the investigations. Then please move to the next slide. This I have told before. Next slide, please. Next. So these are my provisional diagnosis, sir. Nephritic syndrome, maybe, sir, with RPGN. And etiologic diagnosis was first probability was PIGN, then immune complex mediated GN, in which IgA nephropathy and lupus nephritis class 3 or 4 maybe, since the child had active sediments in his urine. So next slide, please. The patient was started on hemodialysis. He received 2 sessions. The patient had anemia, And so prior to biopsy for optimization, we had to start him on hemodialysis, and he needed 3 units of PRBC. And he was done kidney biopsy on day 4. But on the same day, his immunological workup came back. Next slide, please. All were normal except for anti-GBM, which came back positive. It was not we haven't considered it. Then next slide. So now the issues where he had no pulmonary symptoms, he was hematuric but non-oliguric. His anti-GBM was positive. Serum creatinine has rapidly rose from 2.1 to 6.1, and kidney biopsy was awaited.
How much was the titer of anti-GBM?
Sir, it was qualitative assay, so it was positive only. We don't have the titer. So with this, according to KDIGO 2021 guideline, whether the alveolar hemorrhage is present or absent, if we don't have the reports, confirmatory reports in 24 hours, we should move ahead with glucocorticoids and plasma exchange. And so we did that. Next slide, please. So we started with IV MPS for 3 consecutive days, followed by oral prednisolone. And oral cyclophosphamide was also planned, and plasma exchange was initiated. It was started from day 5. We did kidney biopsy on day 4. Next slide, please. So kidney biopsy came back on day 7, and on LM we had 16 gloms, and all were, that is 100% had cellular and fibrocellular crescents. There was severe acute tubular injury, and IFTA was 20%. Next slide, please. On DIF, it was confirmatory that it is IgG, and EM was contributory. Next slide, please. Next. Yeah. So the previous one, please. This is a comprehensive investigation chart. Just 1 month prior to this episode, he had got his hemoglobin done, which was 12.6. Pre-hospitalization, it was 10.6. And when he presented to us, within a span of 5 to 6 days, it has decreased to 6.75. And serum creatinine has increased from 2.1 to 6.15. And we have given him 2 sessions of dialysis and 3 units of PRBC and plasma.
Was CT test done ever after the biopsy?
There was no respiratory symptoms, and there were no X-ray was done. It was non-contributory, so we never.
So how do you explain the rapidity of fall in hemoglobin? You said that few weeks back his hemoglobin was okay, and now
Yes,
his hemoglobin dropped. So suddenly, where did he lose the hemoglobin?
Sir, he never had pulmonary symptoms initially. Our diagnosis.
No, but he may be, but you would think that if the hemoglobin is dropped so much,
yes, sir.
Maybe that he has had a pulmonary hemorrhage, which is not clinically become evident.
Not clinically.
But maybe a CT scan would have picked up.
Yes, sir.
I'm
but
still not sure why would his hemoglobin. Obviously his hematuria, microscopic hematuria cannot cause this kind of.
Sir, he had gross hematuria, sir. He had cola-colored urine. The urine.
Cola-colored urine is okay,
but that will not lead to such degree of anemia. Sir, we had a plan. Had we considered it to be done, suspected anti-GBM before, we would have planned it before. But we had like 4 days have passed, and we were getting results. So it was done, but it was done quite later on. Like
no, Dr. Shalini, the point here Dr. Kher wants to make is that you don't have to have clinical symptoms always in diffuse alveolar hemorrhage. So whenever you are dealing with a case of anti-GBM with such a drop in hemoglobin, it is always a good idea to have a CT scan.
Yes,
in the beginning, in the later stage, after 4 days, 5 days, it doesn't matter. The point just simple here is that irrespective of the symptoms, if there is drop in hemoglobin, in a case of say anti-GBM, it's always a good idea to get a CT chest, HRCT chest. Simple HRCT will show you whether there are alveolar deposits.
Was it done later?
That is the only point. treatment
it
does
was done
not.
later on, sir.
Yeah, yeah. Okay.
It was done later
That is
on,
the
but
yeah.
it was
That is the
also not.
only point, that you don't
Yeah.
have to wait for the symptoms. That's it.
It was
Right.
done later on, sir, but there was it was even that was not contributory of it was not suggestive of pulmonary hemorrhage, sir.
Go ahead. Go ahead.
So our final diagnosis was rapidly progressive glomerulonephritis with focal necrotizing crescentic glomerulonephritis, anti-GBM-GN. So the challenges we had was kidney biopsy confirmed anti-GBM disease, but it showed 100% crescents, which were cellular to fibrocellular. IFTA was 20%, and as patient had no feature of DH. The KDIGO again says that in patients who patients should be given glucocorticoids and plasmapheresis in all patients with anti-GBM-GN, except who have been treated with dialysis at presentation, had 100% of presence, and do not have pulmonary hemorrhage. Our patient required dialysis at presentation. He had 100% of presence, and he had no feature suggestive of pulmonary hemorrhage except for the decrease in the hemoglobin. So, next slide, please. So, our dilemma was, what about Plex? Should we continue, or whether we should have not started it in the first place? So, the points were, next slide, please. The patient had already received 3 sessions of Plex till we got the reports and the kidney biopsy, which showed 100% of crescent. He was symptomatically better. He did not require any HD after day 2. Urine had started to clear, and his serum creatinine was 3 mg per deciliter. Next slide, please. So we continued with our ISA and Plex. Day 8, that is day 7, we got the KBX report and we repeated the anti-GBM the next day. It came back negative in next 2 days. And so we continued with Plex. Total sessions given were 6. And he stayed with us for 15 days. And he received total 2 HD sessions, 6 Plex sessions, and 3 units of PRBC. And along with that, 6 units of FFP. And on day 15, the patient was discharged with a serum creatinine of 2.48 mg per dl. Next slide, please. And on follow-up, the immunosuppressives were tapered and stopped. There were no adverse effect except for the steroid phases. The patient has been on regular follow-ups for the last 10 months and has recovered renal function and is normotensive on one. He is currently on one antihypertensive, that too ACE inhibitor. On last visit 2 weeks back, his serum creatinine was 0.9 and anti-GBM antibody titer was done. Qualitative assay was done, and it was done during the 3rd and 6th months, and it was negative. So next slide, please. This is the comprehensive chart. So his creatinine now 11-month post the episode was 0.9. And hemoglobin has normalized, and his albumin is negative, and RBCs are negative, and he is in complete remission now. Next slide. So this is the timeline of the events which happened. He had the URTI on day 20, cola colored urine, which developed on day 10, nausea, vomiting, day 5 prior to the visit, and he presented to us with proteinuria, hematuria, hypertension, and renal dysfunction. He received HD and PRBC day 1 and 2. Plex started. Kidney biopsy was done on day 4, and then Plex was started. Anti-GBM was positive, and kidney biopsy came back, which confirmed the anti-GBM on day 7, and he was discharged with creatinine of 2.28 with minimal hematuria, and on day 15. Next slide, please. So to conclude, our case was an adolescent boy who presented with nephritic syndrome, and on clinical grounds, diagnosis favored PIGN or IgA nephropathy, and we stuck with the protocol of comprehensive immunological examination and low threshold for kidney biopsy, which helped us clinch the diagnosis and salvage the kidneys. Thank you.
What is the
Dr. Pritpal, Yes.
What is the message about immunosuppression you are giving?
No, before you say, I think this patient most likely behaved like a post-infectious crescentic glomerulonephritis. The outcome of this patient was like a post-streptococcal or post-infectious glomerular disease, crescentic glomerulonephritis. There is one test which is qualitatively done, anti-GBM. I'm not so sure, 100% sure that this test was. The biopsy, see, the biopsy has
linear
if you
IG.
have if you I am not 100% sure that this diagnosis is right. His behavior, this would be 100% crescentic anti-GBM disease starting on dialysis. There are not many case reports that this kidney function has improved to 0.9. Dr. Verma, I don't think this patient behavior is like a post-infectious.
I fully agree.
There is only one crescentic nephritis which recovers like this. One is post-infectious. The other one could be a vasculitis. And I think, Manish, you are there on there. What's your impression? Do you think that this is like an anti-GBM disease?
Sir, I agree with you that
behavior is like post-infectious.
Yeah, so anti-GBM disease usually do not respond well. So there was also dilemma that whether we should treat these patients with immunosuppressive agents or not. But there are case reports, sir, and in fact, we have also published one case report from PGI also, a case of anti-GBM disease with 100% crescents and treated with immunosuppressive therapy and plaques and then improved completely. So again, you can debate that these are like isolated case reports of whether there are other factors which are involved and anti-GBM is just bystander. Even in biopsy, there is just bystander, linear staining and something else is happening, which is causing this rapid improvement. It may be there, but there are some case reports are definitely there. But by and large, it is not a common thing that they improve completely.
And
Sir,
keep in mind, in children below 20, anti-GBM is rare. Is very rare.
Very rare. Very rare.
This child is 14-year-old because the common age, the anti-GBM is a bimodal disease, 20 to 30 years and over the age of 60 years or so.
Yes.
So
we have an experience of 4 adolescent patients, and only this child has survived after being diagnosed with anti-GBM. All 3 we have lost, 2 females and 2 males. And we will be very soon publishing this case series, sir. We had an experience, 2 females who had, one had atypical and the other one had typical anti-GBM. And both of them, one she expired within 15 to 20 days. The other one is CKD now. The other male child, he had typical anti-GBM. He was on, he was planned for kidney transplant, but he succumbed to illness. And he is the lone survivor. And that too also.
I support you on that, because if you are having anti-GBM positive, you are having IgG linear staining, we can't get away from that. That is but the patient child has behaved in a different way. So Principal, your comments now. It is your institution's case.
I agree with both of your comments, sir. Dr. Kher has said this is more like a crescentic PIGN. Definitely, we were also thinking of that, but with the biopsy and anti-GBM serology, there was a little doubt about this is a case of anti-GBM disease. Definitely, these are very rare in a pediatric age group, and that was the real dilemma when these reports came and we had biopsy to whether start on severe immunosuppression with plaques or not, because there were a few things. 100% crescents again going in favor of anti-GBM, but 100% crescents and patient on dialysis at the time of presentation are a few things there. This is not advised to start with to go with plaques. So there was dilemma with our team also as a whole. All of us were in a fix, and we discussed with other institutes also. But one thing very important was this patient has no oliguria, and in fact not a definite decrease in urine output. It was almost more than 1 liter at any point of time, and most of the times it was 1.5 liters to 2 liters. So keeping this thing in our mind, we went with plaques and severe immunosuppression.
Yeah, I think that is one message, which is, of course, the recent guidelines say that if the clinical diagnosis is there and serology is supportive, you don't have to wait for biopsy. You should straight away start immunosuppression, which was started in this case. You did a biopsy on day 4, but
Yes.
the immunosuppression was started on day 3. And that is the recommendation at present. Yeah, I think, yeah, any other comments? I think very interesting case. I mean, undoubtedly, 100% crescents, patient remains totally
Yes, sir.
non-oliguric with a normal urine output. Yeah.
Yes.
So we have
This was-
many atypical cases also in the adults, and all of them have become CKD now. And this adolescent boy with 100% crescents and anti-GBM positive, he has recovery of renal function. He has totally recovered his kidney function, and I think he's only one of a kind.
This is what Dr. Kheri is emphasizing.
But you said C3 is normal. I
Yeah,
mean, if
yes.
you were talking about
C3 and C4 was
post-infectious,
normal.
C3
C3
is
and C4.
normal, ASO
Yes,
is
sir.
normal.
Yes, sir.
Interesting, but yeah. Yeah.
Yeah, no, but
Yes.
post-infectious, you may have many of these infectious markers. There may be other infections which are, because there isn't a sore throat or something. He had an upper respiratory catarrh, but whether it was streptococcal or not is not sure. You may have had other illnesses. No, I'm only, we have had a patient in whom, this is way back in early 2000 at Apollo. Actually, we had a patient who turned out to be anti-GBM positive. But later on, when we sent, this was again a qualitative test, we sent the blood also, because that time the blood was being sent outside, and we sent a quantitative test, and it came out as negative. And we had this recovery of this patient. He also had accidentally fumes. Actually, he was accidentally exposed to fumes, and 2 weeks later came with glomerulonephritis. We did a biopsy. The biopsy showed a linear kind of staining, and we got an anti-GBM test that qualitatively positive. So we were very confident. But this patient recovered, and when we sent the same blood sample which had shown positivity outside for quantitative testing, it showed that the anti-GBM was negative. And we were in early stages of immunofluorescence, and our immunofluorescence, it was labeled as anti-GBM. No, that's the reason I felt the behavior was, I've seen a patient with crescentic, 100% crescentic post-infectious glomerulonephritis. That is one condition where recovery occurs completely. And so the behavior of this patient, although it's an anti-GBM disease, was like an post-infectious glomerulonephritis, which is rare in this kind of a situation. But there are case reports. I'm not, obviously there is huge variety which can happen in clinical medicine. I'm aware of that. I'm not denying that. But this would be very unusual, and that makes it very interesting. It is truly, what I would do, see, as a person, what I would do, Dr. Prithpal, is if you have this patient's blood, I would still subject it to find out if that original sample, if we don't keep usually samples, but if labs have samples, you have an institution, and if you have, I would send it for confirmation for anti-GBM disease again.
And secondly, if it is anti-GBM, Dr. Prithpal, what about the immunosuppression part? Because today, do you give maintenance immunosuppression in them? Because the recommendation today is you have to give maintenance immunosuppression for 2 years.
No, sir. In anti-GBM, we are not giving maintenance.
Because you stopped immunosuppression
within 2 months.
Within 2 months. And what is the recommendation for anti-GBM?
Sir, anti-GBM disease are not known to recur. So usually there is no maintenance immunosuppression given in those cases.
Because even plasma exchange, the recommendation is at least 14 sittings of plasma exchange.
Or anti-GBM comes
Or,
negative.
Or it
and
becomes negative.
negative. So we stopped when we got anti-GBM negative report. After that, we stopped.
Mhm.
Yeah, I think in this patient, if he has recovered completely, there's no point in giving immunosuppression at all. And the question predominantly because anti-GBM disease doesn't recover in most of the time and will go on to get on to ESRD, then many of these patients, once they get antibody negative, you are either transplanting them if they go for transplant, or if they haven't recovered, then they will continue on dialysis without immunosuppression. So by and large, immunosuppression will not continue for too long in either case.
Yeah, but you will agree, Professor Kher, both were very interesting cases.
Yeah,
today.
definitely.
One
Very
was query lupus enteritis.
Yeah. Today.
And second, the undoubtedly anti-GBM, which behaved in a very different way. So, yeah, your final comment before we close.
No, I would.
Both the
Yes.
residents for wonderful presentation.
Yes, very good. Interesting cases, no doubt about it. These always, that's what makes clinical medicine so interesting, is that many times you're not able to confirm these diagnoses convincingly, so that 100% of the people who listen to these cases, same enteritis also. I'm saying lupus enteritis, it was treated as lupus enteritis. And I'm not saying that it was wrongly done so. Clinically, you have to make decisions even in absence of maybe 100% conviction of that diagnosis, but clinically we have to make these decisions, treat the patient. You can't tell the patient that go home, I'll go and read and all that. So you will make decisions. And I think these kind of cases make clinical medicine so interesting as well as challenging, and for all people to learn in future. But one message which I would say is that in clinical medicine, we must, as much as we must, try to confirm our doubts and diagnosis as much as we can. By either in India, we don't store samples and we don't keep it. And so sometimes when a sort of a doubt exists, if we have samples, we should be able to confirm it either now or later, sometimes later also. And that's what happens in many other countries. I hope we also start doing this. Is a private medical institutions in most places where it may not be. But today we had these two institutions which are government institutions, and I would hope that they have a policy or a method by which they can keep samples, and probably they may be of use and confirming diagnosis later. But interesting cases, and I think we must thank also
both of them.
Both
keep
speakers
in
and
mind,
Dr.
we had,
Principal as well as Dr. Manish. Manish always presents with such a flavor and all. If I had not stopped him, he would have continued with the differential diagnosis and with his resident on whether a biopsy should be done, not done, when should be biopsies done, and all other discussions about lupus. Thank you both of you.
Keep in mind that today we had over 200 attendees. So that goes to prove that both the examiners are pretty popular. Thank you very much.
Thank you, sir. Thanks for the invitation. Pleasure was all ours.
Very good.
My pleasure, sir.
Thank you.
Thank you,
sir.
Thank you,
Dr. K, Dr. Armaji.
Thank you. We must thank also Micro Labs for their continued support for Regain challenging clinical cases. And today's were really exceptionally such a challenging case. Thank you very much.
Thank
Good
you.
night,
Thank you, sir.
everyone.
Good night.
Bye-bye.
Thank you all.
Bye-bye.